Health reform. It is a political inevitability that Obamacare, the Affordable Care Act, will be modified in a major way, if not erased entirely. It is more important to get it done right rather than to get it done quickly. The Obamacare model was actuarially unstable and unsustainable from the beginning, but a return to what existed before would be foolish and probably impossible anyway. Rate structure, pricing, and public expectations have changed dramatically. There's no going back. The good news is that we now have a golden opportunity to fix the health insurance system. Note that I say the health insurance system, not the health care system. The fact is that we have the best health care system in the world. At its best, it's extraordinary. At its worst, it's still better than most of the rest of the world. I'm not suggesting that there isn't room for improvement. There is. Disparity in treatment and availability are problems and need to be addressed. But for the purposes of this conversation, let's focus on the big problem, and that's the health insurance system. There's a difference between health care and health insurance. Health care is doctors, nurses, technicians, hospitals, and clinics, the people and institutions that actually provide the health services. Health insurance is a funding mechanism. They pay for doctors, nurses, etc. that provide the service. Health insurance also helps pay for medicine and medical devices. Healthcare provides the service. Health insurance, through private companies, along with the government through Medicaid, Medicare, provides the money. As a former insurance professional, I will tell you that the insurance company is not your friend. They do what they do in conformity to the insurance contract, state law, and other regulation. No more, no less. In this regard, they're kind of like banks. Maybe worse, but certainly not better. They do not love you any more than the banks do. The TV commercials that profess otherwise are nonsense. Did you see the one where Chuck Norris kicks the salt shaker? And if an insurance company says they want to assign you a patient advocate to make sure that you're getting the best possible care, it's really only to help them control their costs. Now, as a sidebar, I'll tell you that as an agent, workers' compensation was literally my bread and butter. And I want to tell you that if you're off of work due to a work-related injury, you may be assigned a nurse case manager. That's different from a patient advocate. Nurse case managers are often an injured employee's best friend in getting the care they need, so work with them. That's my advice. I know what I'm talking about. I'm a former insurance broker, and I was an appointed agent for Blue Cross, Blue Shield, Aetna, Humana, Assurant, United Healthcare, and others. Half of my book of business was health insurance. Since then, I've worked in a hospital, a good one, focusing on technology to prevent hospital-acquired infection. Working at a hospital gave me a new perspective from the service provider side of the equation. As an aside, I will tell you that no one knows less about health insurance and its associated costs than doctors, nurses, and technicians. They have little understanding as to how their activities are financed. I once saw Dr. Ezekiel Emanuel talking on a news program. He is Mayor of Chicago, Rahm Emanuel's brother, who at that time was still White House Chief of Staff. Dr. Emanuel was talking up Obamacare, and to enhance his credibility, he proclaimed that he knew what he was talking about because he's a doctor. And then he proceeded to spout a bunch of misinformation. It was really annoying. I don't tell him how to practice medicine, so why does he think he can hold forth on health insurance? Before a pundit spouts off about the system, they should be able to explain why the usual, customary, and reasonable model was abandoned and replaced by relative value units and resource-based relative value scale with its geographic and market components. Along with the master fee schedule and negotiated rate, these practices determine the cost of everything from a tetanus shot to a kidney transplant. No one who doesn't have command of these facts should present themselves as an expert. Now that's a mouthful. It sounds like a bunch of gobbledygook, and to some extent it is. And the only reason I bring it up is to illustrate what a weasel game this has become. This pricing model is so confusing that only insiders really are able to decipher it. Look at an explanation of benefits sometime, an EOB, and you'll see what I mean. Okay, lastly, I have reached a point in my life where I am an active and ongoing consumer of healthcare services. I have firsthand experience dealing with all the frustrations related to service, coverage, and billing, just like everyone else does. Improving upon Obamacare. I had a sneaking suspicion all along that those who passed Obamacare knew that it would fail, and then single payer, which was their real goal, could be instituted. I want to talk about what we should do, what we should not do, and why. Panacea. It's a noun, a solution or remedy for all difficulties or diseases. Informal, a magic bullet. Another synonym for panacea is single payer. Single payer is an extraordinarily bad idea. There are a lot of people, many of them good people, that think it's a great idea. It's not. People who support a single payer system are optimists. Optimist, a noun. A person who tends to be hopeful and confident about the future or the success of something. My definition is, an optimist is a person with no experience. Society needs optimists, but in this case they will tell you that Canada and the UK have national health, and it's wonderful. It's not. It's hugely expensive, and the quality is poor. They will tell you anecdotes about somebody they know that got sick or injured while on vacation and received wonderful care. It's like being back in the dorms with a bunch of political science majors who are convinced that, contrary to all the evidence, that Marxism is the answer and really would work if it was implemented properly. The fact is, the NHS is not good. There are people that die waiting for bypass surgery that they would get here almost immediately, even if they were on Medicaid. In Britain, if you have the money, you see a so-called private doctor, concierge medicine. It represents a two-tiered system that separates the rich from the poor. The rich live, and the poor take their chances. If you go into a hospital in Britain, this is where they put you. It's a ward. You don't want to be up in this, John. John, a noun, chiefly eastern Pennsylvania or southern New Jersey. It is used to refer to a person, place, thing, or event that one need not or cannot give a specific name to. If you are recovering from surgery or have a compromised immune system from chemo, a private room is not a luxury, it's a necessity. Hospital-acquired infection rates in Britain are horrific because wards are ideal environments for the spread of pesky organisms from MRSA to C. diff to VRE to CRE and other superbugs, or worse yet, Creutzfeldt-Jakob, which is not even an organism but a prion, a self-replicating protein that eats your brain like some horrific spin-off from The Walking Dead. I'm not making this up. This is the hospital that I worked in. If we implement single payer, do you know what it'll be? It'll be just like the Veterans Administration. How would you like that? Because that's the model. Consider this. What does the government do well? It's not a trick question, and the answer is not nothing. Government does do some things well, but providing services is not one of them. Ironically, one of the best examples of things the government does do well is part of the VA. Think of the GI Bill. Millions of homes came into being because of veterans' housing benefits. Many millions of veterans went to college because of veterans' educational benefits. It must be pointed out that the VA and the federal government provided the funding, not the actual service. They didn't build the houses or operate the universities. They only provided the funding. If they did provide the services, it would be a total train wreck just like their hospitals. So where do we go from here? What I propose is a public-private consortium to finance healthcare, an integration of private insurance companies with a safety net underneath for indigent and uninsurable citizens that incorporate the better aspects of Medicaid, Medicare, and CHIP programs. It would not be reinventing the wheel. I would reform the way that we finance an already excellent healthcare system. Mandatory participation. If you drive a car, you have the potential to crash and do economic harm to others. Mandatory car insurance was instituted to address this. Likewise, if you live in this society, you have the potential to cause economic harm to your fellow citizens by getting sick or injured and incurring medical costs that you can't pay. Someone has to pay. It ends up being taxpayers or the insured. The insured are overcharged to subsidize the uninsured. Contrary to myth, hospitals will not deny care and drag you to the curb if you don't have insurance. The fact is, you'll probably get the same level of care as someone with a so-called gold-plated plan. We need mandatory participation in the system so younger, healthier, low utilizers pay into the system to offset older, sicker utilizers. That's how insurance works. Everybody into the pool. Insurance works on the notion of the law of large numbers, a statistical axiom that states that the larger the number of exposure units independently exposed to loss, the greater the probability that the actual loss experience will equal expected loss experience. Here again we have a mouthful, but unlike with pricing structure, the law of large numbers is a real thing. And all you really need to know that beyond question, it's true and provably true. It makes insurance costs predictable, and controllable. For the system to work, there cannot be an opt-out option for cronies, political supporters, politicians, or anyone else. Actuarial stability. Actuaries are very useful, even if they're not much fun at parties. Participation in the system must be consistent and known. Otherwise, the system becomes actuarially unstable and spins out of control, just like Obamacare is doing right now. Having a system that is backed up by law will allow the actuaries to generate good information and will enable sustainable pricing and good decisions moving forward. Pricing. Pricing must be adequate and correct. It's not that complicated. It's not calculus, trigonometry, or even math. It's arithmetic. It's adding and subtracting. There must be enough money coming in from premiums and public funding as there is going out in the form of claims and the cost of overhead to administer the system. When pricing is right, the system will be sustainable. Sidebar. The insurance companies have used Obamacare as a smokescreen to do some major price gouging, exactly what the politicians said would not happen. Price transparency. Transparency enforced by law must be instituted. The way the master fee schedule is discounted through negotiated rate is a colossal shell game designed to obfuscate and conceal. Did you know that charges for the same services vary depending on who you are and what insurance coverage you have? Medicaid reimburses the provider the least, followed variably by insurance carriers who negotiate themselves huge discounts. The uninsured, the people least able to pay for care, are charged the most. It's highly discriminatory. As it stands now, you can reasonably expect more price transparency at a used car lot than a hospital. Tort reform. Meaningful tort reform is essential. Billions of dollars of tort-related costs burden the system. Awards for injuries that are a result from real malpractice should be paid fully and equitably. But too often, awards have come to exceed reasonable compensation. On top of that, juries sometimes award absurdly high punitive damages. Medical tragedy must not be a means to cash in big time or become a means of economic redistribution. When it does, everyone ends up paying. State versus federal regulation. Generally, I am against the federal government involving itself in activities currently handled by state governments. This case is an exception. The major companies already operate in multiple states, and in the case of Anthem WellPoint, they operate multiple carriers in multiple states. The problem is that each state regulates differently. It's a messy patchwork. We would be better served by one federal set of regulations. Article 1 of the U.S. Constitution already mandates that the federal government is to regulate interstate commerce. Consumerism. If there is one thing that Americans excel at, it's shopping. A system that empowers consumers will improve quality of service and help control costs. Some procedures, like corrective eye surgery and cosmetic surgery that is not covered by insurance, have a high degree of consumer engagement already and provide a valuable example. Wellness. Wellness programs and preventive care help control costs and improve the quality of life. If mandates and financial incentives are put in place, everyone will benefit. The most important ingredient in health insurance reform is participation by a knowledgeable public, stakeholders, and knowledgeable politicians. I stress the word knowledgeable. Now remember I said it's important to get this done right rather than quickly. And here's another sidebar. Those people who had expectations of Obamacare being replaced in the first 100 days of the Trump administration were deluded. It took a year and a half to get it in place. It is likely to take that long to replace it. Those are my thoughts. You can put your comments below.